Okay, so my name is Melanie Jacob, and I've been a registered dietitian for 40 years. This is my 40th year. I got into eating disorders back in 1990, actually way before 99, but in Boston Children's Hospital. And I was in the LEA Fellowship, which allowed me to experience the adolescent medicine focus as a dietitian on the team of doctors, nurses, therapists. And so I was told by the doctor that they flattened the pyramid and no longer are dietitians considered less part of the team. So that really empowered me to really move into the eating disorder world with a lot of confidence and a lot of kind of drive to really grow and to take my role as sort of an equal part of the team. When I started my private practice in Michigan, I was having a traditional method of meeting with the teenager and having the parents in the waiting room and having the parents come in at the last few minutes. When the Maudsley research came out in 2000, I want to say maybe 6, I started reading it, and then a therapist in my community said, would you be willing to try this approach with this patient? And I was like, yes, this makes sense to me. So we flipped the switch. I had the adolescent in the waiting room for most of the time, other than the introduction and then the end. And then I had the parents in the session for the majority of the session. And this sort of changed my whole approach to all of this. In about 2010 to 12, Therese Waterhouse asked me to be a co-author, and because she was doing family-based treatment only like a couple months. And all of a sudden I'd been doing it for like years. And I was like, isn't everybody doing this? She's like, no. And I was like, oh, okay. So I was very lucky to have a very collaborative physician at a hospital who had an adolescent kind of track for eating disorders. I had a couple nurse practitioners. I had therapists in the community that were allowing this approach and allowing the dietitian to have a value in the team. So fast forward, the Edge 2 was born. And I feel like it's just, it's a tool that has to get in people's hands, whether you're a therapist, a doctor, a dietitian, whatever role you play. I think it's effective, especially if you can repeat the test, as well as if you know how to do the psychoeducation piece, or you don't feel afraid to feel like, okay, as a dietitian, should a therapist be doing that? But you as a dietitian can do that because you know the body, you know physiology, you know growth and development. So that's a big part of the background and the why I really wanted to give back to the field. And this 4-week kind of series is to, number one, recognize if there's any edits that needs to be happening in the Edge tool. And specifically the word obesity is on that list, and it affects some people not being able to want to use it. And then some other questions about, do we need the frequency? Could it be automated? Is it an informant that's helpful? And these are all the things that I'm looking into. And yeah, just doing case studies. So I want to just, I have to just talk about this. And it really, I heard it from a news channel. Can you see the article? Okay. So I heard it driving in the car, and I was just like, what? Are you kidding me? I was just like in denial that they were actually saying this, because we've done this research before, and the benefit that I can say as for dietitians is that we have to recognize that if this is in the print, we have to, as eating disorder specialists, we need to be the specialists to do this care. And we need to do it properly without all the sort of the infrastructure of the medical community using terms, approaches. I don't know. I mean, family-based treatment for anorexia is putting the parents in charge. And, we assume that the child is been hijacked, their brain has been hijacked. If eating disorder dietitians could get involved at a very high level with training medical staff, training other dietitians, we can maybe deflate some of this, because if they're going to do it, this is what they're going to do. And if we can somehow be in there and even having the EDGE tool used, because if you have an atypical anorexia right now in your office, and if you take the EDGE tool with them, you will see full symptoms as you do with a small, thin, skinny anorexic girl. I had many, many boys and girls who were, I call it constitutionally on a higher growth curve. I call it constitutional growth patterns, consistent with their genetics, their height, their family history. So I could validate they were on a constitutional growth gen that was normal for them without using obesity, overweight. And a lot of times I had to help boys and girls get up to sort of 90 to 95th percentile at times to be better, to get better from the restrictive eating and the malnutrition. So I think I just had to bring this up. It's probably a whole nother discussion. If we have time at the end, we can talk more about it. But I feel like shocked and saddened about this new study that came out. And I feel like, okay, how are we going to react? We can just stay in our corner and just do our eating disorder work and sort of gather all the residual kind of damage, or we can like approach healthcare systems and get involved at a very high level with, like, you know, influencing some of the leaders. So I don't know, for whatever that's worth. So,
and Melanie, I think that's a really good point about how the EDGE can be used, is noticing, like, and I was pulling some of my EDGE forms this week and noticing, you know, some of my clients that they're so symptomatic, but their weight is quote unquote normal. And, you know, I mean, I think that's some really good data that EDGE can pull. You know, and I don't know if anybody else here is on the IFED listserv, but the International Federation of Eating Disorder Dietitians. I'm about to send out one more email because I sent something out saying, hey, why don't we get together and start educating pediatricians' offices about Satter, and Ellen Satter, because she has so much clinical research. And I think that's something doctors would respond to.
yes.
So I'm going to work on pulling that together, because I don't have the capacity to do it all myself, but
Right.
definitely if we can get a good group together. And I have a little in with Ellen Satter too, because one of my colleagues in my office works for Ellen Satter Institute. So I'm going to talk with her and try to get some good cooperation from them, because I don't want to, you know, use their materials without consent and things like that. But they also freely give away a lot of information on the website, right, and that kind of thing. So really want to try to get to work on that. So feel free to email me. I'll type my email into the chat window, and you know, you can contact me that way, right, if you want to be a part of that.
Excellent. A dietitian work group to educate pediatricians, healthcare systems. I think this is absolutely physicians. I know Therese does a lot of training to psychiatry and family practice doctors, you know, who are in like their third year or whatever their rotations. They could rotate through the office. I mean, there's so much that we can do. So anyways, so today I want Julie to, and I don't know if you have your intern with you today, but
I don't today, but
so another charge. Last week she was here, she had her intern or a student or volunteer. We really need, as experienced dietitians, to try to bring in some of the younger people, newly graduated, coming out of, you know, their internship or in their internship, and teach them about the basics. And again, just encouraging people to make that, you know, part of their, maybe they already are, but, you know, make that part of their priority. So with that, Julie, if you need to share a screen or if you want to just talk, that's fine.
Yeah, I'm going to try to share, because I pulled it up.
Okay, let me just see if I can make you a
here.
co-host.
Will it let me? No.
Okay, I will.
If not, I can just talk through it.
No, I can do it, but I'm just looking for the view.
And actually it was funny because as I was going through pulling things up, I was like, oh, like I didn't use it even as much as I thought I did. And there's some clients I could definitely use it for. So I need to, because I was pulling open charts like, oh, I'm sure I have a form on this one. Oh, I didn't get that. I need to get that. But I did find a good one that we can look over together. But if I can't display it, I'll well, I wonder if
you're in. Sorry,
Okay.
it took me so long. I'm out of breath.
That's okay. All right, here we go. Let's see if it'll do that. Okay. Can everybody see that? So I have them side by side because I thought it was easier to kind of look at both. But so the left one is the first one, which was at the end of March, and then the right one is the second one, which is close to the end of June. So I try to do them every 3 months if I remember, and I try to just look at that. What I tend to do in my chart, my online charts, is put the edge near the top so that I know when it was last done, and I kind of see it every time I open the chart. And I just put it as a separate page near the beginning of the chart. So some of this is going to be hard to read because I scanned it and it was from, a handwritten copy. I copied it over from the chart and that kind of thing. But so this is a 23-year-old female. She's 5'6". And when I first saw her in March, she was 118 pounds. So her BMI was 19.1. Her diagnosis was anorexia nervosa, restricting type. And she was just coming out of inpatient treatment. And I say that she was just coming out of inpatient treatment, but she actually finished inpatient treatment and went a couple of months without seeing a dietitian. And so she was seeing her therapist, but she wasn't seeing a dietitian, and her therapist had recommended she needed to see someone, and she finally did. And I can't remember with her, I think she did okay with her dietitian in treatment, but she just didn't really connect and feel like that was a big piece of her treatment. So I know for a lot of our clients, when they feel really connected to their inpatient dietitian, that can go two ways, I guess. Sometimes they don't want to find somebody new, but a lot of times I find that they really want to get connected with an outpatient dietitian because they see the value of that part of the treatment process. And so she just didn't have that big connection and just she felt like she was doing okay. Right. And she didn't need that piece. A lot of times when I have a client who already has an eating disorder diagnosis, I don't hesitate to give the edge form. Sometimes when I'm not sure what their diagnosis is, or I'm not sure really how much they know about disordered eating, and especially if they're young, I hesitate to give them ideas because a lot of these behavioral things, kind of can inform sometimes. But I honestly feel like it's most people already know about these things, and either they're doing it or not. So for this one, she already had the diagnosis. So I handed it, I sent it to her. I was going to see if I had I'll just kind of use my cursor, but, so she was reporting weakness, cold hands and feet, constipation, which was pretty significant, her dry skin, and then also she wasn't sleeping well, and depression and anxiety, which are, kind of ongoing background concerns for her. And then obsessive thoughts, and over concern with weight and shape. And she knew she had body image issues, but she didn't really connect it to her eating. But of course, we know that is connected to how we think about our eating and approach them. But so her physiological score here was 18. Behaviorally, disproportionate time spent thinking about food, interest in recipes, food channels, and food shopping. She also worked in a bakery. So that was another thing. Experiencing loss of control with eating. So she had subjective binges, right? So she wasn't actually binging, but she would feel like she was if she ate a croissant or something like that. And then, scrolling down here, avoidance of specific foods. And that was a big one. And I'll talk a little bit more about that too. Eats meals too fast. Hunger and fullness was very difficult for her. And then inability to define or eat balanced nutrient intake, and also difficulty with portions. And then she was also rationing. And that was also had to do with her working at the bakery. It's okay if I eat a baked good, as long as I don't eat too much later, or I didn't eat breakfast. She had permission, that type of thing. With the hunger and fullness too, I really think she identified it better than she wanted to admit. because I think she just didn't want to follow it. And so I think that was a struggle at the beginning. So then her behavioral score was 25 and her total score was 43. And I mentioned the last time we met that anytime I see a number in the 40s and 50s, I think there's a lot going on here. I'm unsure if outpatient care is going to be appropriate. But with her, I knew she had just finished inpatient treatment. So we really were transitioning down, and she was just learning how to deal with things in her home environment. So I didn't get super worried. And also because most of that score was from behavioral. So she had, a little bit more behavioral symptoms than physiological. If I see very heavy physiological, I tend to get more on the alert and think we may need more medical care. And so that's a way to identify. But she did report some diarrhea as well. So constipation was a big issue for her. And it was really just a result of malnutrition and her restrictive eating that had been happening. So she was, her just digestive system wasn't in very good shape yet. But that is something that we just monitored. And I think in her case, I don't think we did Miralax. I think we just did some Benefiber. And kind of kept her meals and snacks consistent, and that was resolving. So in between this 3 months, she actually started to lose some weight after she first saw me, and I consulted with her therapist a little bit, and she was saying, well, she said, I kind of was considering her more in recovery, but maybe we need to buckle down and work on things a little bit more. And part of it was looking at this behavioral, kind of this list of things. And I think I shared this with her therapist as well, to really highlight, things that she could be working on too. So in June, it reassessed, and she had gained 8 pounds, and she was at her goal weight. She was 126.4, BMI 20.4. And of course, I always set, well, I shouldn't say of course, but I always set a range for goal. So I think her range was 125 to 130 or something like that. And I always tell my clients, like, I'm not going to force you to gain to a certain number. We're really looking at health and what's happening. And also, are you eating freely? And are you not engaging in eating disorder behaviors, and hopefully not too much of the thought patterns either. So you could see at the reassessment, her constipation was still happening, but not daily. And so we were still, and these were mild constipation symptoms. She was having pretty regular bowel movements. It was just more of the discomfort and that kind of thing. And her other symptoms improved. She still was having some trouble sleeping at night, but was much improved. And then anxiety was still happening. And again, that's probably going to be an ongoing concern for her, that she'll stay in therapy for. But her obsessive thoughts and her body image issues were much improved. And it's interesting to me because we always have, our clients are always afraid that when they gain weight, they're going to have more problems with body image. But I really think that they tend to have less because they feel better and they realize, like, oh, my body is, healthier at this point. So then with behavioral, still some disproportionate time thinking about food, but this kind of obsessiveness with recipes and things like that, and feeling like she had a loss of control, those types of things had resolved. And then avoidance of specific foods was still pretty big. And it was interesting to me that this wouldn't necessarily come up in session until I gave this 3-month, reassessment. And then I said, well, let's talk about this, because now it's still every day, right? So we talked about that and started doing more with food challenges. So another thing that EdgeForm helps with is reminding us of things we need to work on and giving us, specific areas to target. Eating meals too fast, she still felt like she was doing that on a consistent basis, but not daily. I felt like that improved for her, but she was kind of social, and so she would eat really fast before going out, or those types of things. So I don't know that it was affecting her ability to really eat well, but that was something that we were talking about as well. And then she still felt she wasn't able to identify her hunger and fullness all the time, although her rating on that went down. She just felt like it was happening a few times a week. But her, being able to portion foods and eat adequately, and obviously with the weight results that had improved. So does anyone, okay, so Sherry asked, do you have the client fill this out by themselves or do you do it together? So I give it to the client on a clipboard is what I do, but then I tell them, okay, I said, this is just a list of things that you might or might not be experiencing. And I'd like for you to, if it's something that you're experiencing, I'd like for you to check the box and then also write on the line the number according to the little key at the top for how often you're experiencing that or how often that's happening. And I usually just tell them if it's 0, just leave it blank. So they don't have to check or write a 0, on the ones that are 0, but I said, just if you're experiencing it, and then they can ask me questions. And sometimes they'll ask me things. I'm trying to find one that, they'll say, well, what's a disproportionate time? Like what's a disproportionate time spent thinking about food? And I'll say, well, are you thinking about food when you probably should be thinking or could be thinking about other things, and then they'll say, oh, or they'll say, no, I don't do that, right? So sometimes they'll ask questions about, what that means. But, for the most part, that I just sit there and then I just wait for them to fill it out. If it's the initial session, I usually have other paperwork I'm going through for the initial session, but I just, try to sit and wait and be patient for them to fill it out. And some clients fill it out very quickly and other clients take quite a bit of time. So I had one client taking a long time to fill it out and I was like, oh, and it was a follow-up one. And I was like, oh, I thought she was doing really well. She's taking a long time to fill it out. And then she handed it back to me and it was blank. So she was reading it over to see, but she was like, nothing. So it was kind of cool. But yeah, so I usually give it to them in session. So you can send it ahead of time, but I kind of try to determine if I'm going to give it to them or not. And so I don't always know that for sure until they're in my office. And then I do feel like it helps them to hear those instructions, even though they're clearly at the top of the page. But I just feel like it helps people to not feel overwhelmed because it is a big page with lots of boxes and lines. Yeah. So I feel like it helps that way. But
so Julie, how long was her course of illness? Like she came out of residential. So how long do you think she was in treatment before she took this tool?
At least a year from when she started to want to get help, I would say. Because she, that process of, well, I want to get help. So, what do I do? Well, I'm going to get a therapist. Well, now it's determined I need to get an assessment. Now I get an assessment. Now I go to treatment. And like I said, it had been, so she saw me in March. I think she was discharged from treatment in October or November of 21. So it had been several months that she hadn't seen a dietitian. So yeah, she was in treatment for, a good bit of time before this tool was used. Yeah.
So this speaks even to I want to call it supportive maintenance that dietitians can provide, even when they get to their goal, like being part of a sort of a distant team that maybe the therapy keeps going more intensely about the anxiety, or she gets pharmacological help, but you can still be checking in and offering a lot of value to the team, and knowing she was probably in treatment, getting renourished. I don't know, how long was she in treatment? 2 months, 1 month?
I think she did a full 3 months.
3 months of treatment.
Started
so imagine that much nutritional restoration in 3 months. Now we don't know if she dropped weight from October to March. Probably went backwards some, but just to see how long it might take even for some of these things to resolve. So this is really good.
Yeah. And I think it's good too, to review. I mean, so even when she first came to see me, her BMI was 19.1, which isn't super super low, but, you know, and I've had some clients be perfectly healthy at a BMI of 19. But, you know, of course, for her, it was like, well, this fear of being overweight, it was preventing her from really getting to where her body needed to be, which was, you know, 8 to 10 pounds more. And so, and of course, on a 5'6" frame, she carried it fine. And she didn't really feel, and this is something too, that, you know, I talk with a lot of my clients about is that it's all over weight gain, and it's internal weight gain. We're not talking about just adding 1 pouch of weight to your body where you're going to feel burdened by it. You know, and of course, some of our clients are more sensitive about their bodies than others, but she, you know, she really did respond to the nutrition counseling process, and this was really a helpful tool in assessing her. And like I said, you know, I mean, I generally have a feel for how clients are doing, but, you know, sometimes I get the form back, and, you know, if this form had been, you know, the numbers had been still in the 40s or upper 30s, I would have, you know, maybe thought about IOP or something for her, just to really get her going in the right direction. So, but I do feel like also with her starting kind of on the higher scale with behavioral, or higher end of the scale with behavioral, that because she had come down out of treatment, she was still really actively working on a lot of those things. And so it is different for me when I see someone who this is their first time getting any help for any type of eating disorder, and I see it in the 40s and 50s. I'm willing to give it a go. But if I see the next form is not, you know, it's still in the 40s, I'm going to recommend, you know, a higher level of care, just because there's not enough progress being made, and 3 months is too long of a period of time to not make more progress than that. You know, for someone who may be malnourished, or, you know, even with purging behaviors and things like that. So. Yeah.
That's really good point to make, because we have to frame it that this treatment is failing you. You are not failing treatment. So this type of treatment, this kind of level of care is failing the goals and, you know, objectives of your healing and recovery. So we need to look at, you're not failing, but this treatment is failing. So we need to look at a different avenue to best match what will meet your needs. So I always liked framing it like that with patients, so they didn't feel like I couldn't do it, or I didn't do it in outpatient, or I'm failing, or, you know, another negative kind of thing. So,
yeah. And I was going to say
period, no period changes or anything. She was having a menstrual cycle. Right. Okay.
Yeah, for her. And that's interesting too, because, you know, that varies, you know, from client to client. Some clients, it will take a very long time for, you know, they'll lose the period. It'll take a very long time for it to come back. And one of the things I was going to say too, just on the, and I know you're going to talk more about this, Melanie, with the psychoeducation and stuff, but I always try to tie it back to the eating and, you know, how things relate to the eating. And so if some of these things that come up on this form, you know, if it, one of the things that I can do is provide accurate information and nutrition education and education about the body and the digestive system and whatever, to give information for reframing thoughts. And then the therapist would be helping them with how and when and how to catch when they need to be, you know, reframing thoughts, or how to interrupt behaviors or that type of thing. But I feel like that part of our role as the dietitian is to give that information. So, you know, when they're working on things with the therapist, they can say, oh, well, you know, Julie told me that my body needs added fats for hormone production. So that's something I can remind myself that I want to get my period again. So I need to have added, you know, those types of things. So I think that's an important role that we play as far as giving that information.
And Madeline just is asking about the scoring. So Madeline, when I designed this, I looked at some other scoring kind of forms, and they kept it like within the last month. And so ideally I would love to validate this tool, but to do that, you would have to have people fill this out pretty much every day to see if what it measures is what it's measuring. And I'm not sure anybody has the capacity, even a patient, to do that kind of stuff. So you just give it a 1 if it's infrequent within the last month, a 2, if the symptoms happening a few times a week, and 3 if it's daily or many times a day. And then you add those scores up. And so the first column in the top 3 is the physiological. And that's what Julie mentioned. You'll see a very high score when people are more acute. They may need hospitalization. They may need a higher level of care, especially if the pulse is below 60, which I'm going to talk about, or below 50 specifically. And then the behavioral, I always call behavioral the residual parts of malnutrition, because I always saw that the physiological stuff repairs first, and then the behavioral stuff just sort of lingers, and that's how you know what to focus on in your treatment, and specifically, you know, avoidance of specific foods. You could do a whole progression of food challenges or different things like that. I did this intuitive eating questionnaire with clients who restored menses, and I was really curious about their ability to identify hunger or fullness. And the intuitive eating scale, I think the gal's from Ohio, I already forgot her name. Somebody might know her, but she created the scale, and I did not find restored intuitive eating in anorexic clients after resumption of menses for over, I think it was like 6 to 8 months.
Mm-hmm.
So we can talk about intuitive eating, we can encourage, we can teach about it, but literally the ability to understand hunger and fullness for some may not be there, but some may take a long time, even after their body's running well.
One of the things I was reminded of in a sports nutrition continuing education webinar is that hunger has a hormone. You know, we have the hormone ghrelin that signals hunger. And so if someone's not having a period, they're not making hormones adequately, they're probably not making the hunger hormone either. So especially in association with, you know, clients who aren't having their periods, that we should remember that hunger signal. You know, they're going to say, I don't feel hungry. And sometimes I'll ask them, well, do you feel ready to eat? You know, like not necessarily hungry, but like you can eat. And they'll say, yeah, you know, so sometimes that's the start of identifying hunger, of, you know, feeling able to eat. But it can be a very long time,
Right.
Before our clients can really do that and follow it. So
awesome. I think I calculated this real quick. I did 43 minus 16 divided by 43, and she got a 63% improvement or reduction of symptoms. So I think that's a way you can put it into your documentation. You know how we do percent weight loss. Well, we can do a percent reduction of symptoms. And that's one thing I think I would be looking at and trying to give it more measurable tool. Like, how could this be useful in how you communicate? So 43 minus 16 is 27 divided by the 43 initial, she's 62.7. So you could say is she with an 8.4 pound weight gain over 3 months, she's had a 63% improvement of symptoms or reduction of symptoms. And you know, maybe then you could just say risk for relapse includes this, these are the indicators that we're still working on, or these are the risks of relapse, or you can create a whole treatment plan based on awareness of symptoms. And then I always told the patient, you know, when you start getting your constipation is still lingering, but if it gets any worse, then it's an indicator to you that you might be going backwards. So it gives the clients a measure to measure for themselves, like, oh, wow, this is getting more out of hand, this constipation. Oh yeah, Julie told me when it goes, you know, and I have, you know, my cold hands are coming back, or, you know, whatever starts showing up, that's like physical signs to the client to teach them, hey, I might be getting in trouble here again. So does anybody else have any questions? Madeline, one of my programs that my patient goes to the very first week, they wanted her to work on intuitive eating when she clearly stated she did not have hunger cues. Okay, so again, education. That's a little bit of a challenge with Ellen Satter, because what if they have some disordered eating, and you can try to present division of responsibility, but then, and the whole
And Melanie, you were talking about family-based treatment earlier, and I always word it to parents that way, like using division of responsibility. I say, the child is not capable of carrying their responsibilities, so the parents are going to take that over. But then as we move through family-based treatment, the child is going to resume their age-appropriate responsibilities with making choices. So, and that kind of gives parents a little bit of a concrete, like, oh, this isn't going to be forever, that I have to do, basically feed my 13-year-old like they're a toddler, and that's helpful. But yeah, it is something we have to assess on a case-by-case basis.
Yes, very good. So those of you who don't know what we're speaking of, family-based treatment or division of responsibility, family-based treatment assumes parents are put in control of the diet and the meals and the feeding in the first phase of FBT. And it's one of the tenets of, that you don't assume that it's the parent's fault. You assume the parents are a part of the solution, and you empower them to focus on the meals and reducing symptoms. Okay, I'm going to switch over to something really quick. If you go to my website, I'm just going to share, I'm offering this thing for free. If you didn't, I have this, okay. This is the psychoeducation handout that I'm working on to edit. I would love people's input on it. I don't want to give it to everybody, but I think people can't get my Edge tool. So if you go to this part on my website where you can actually go to the Edge tool, it's the psychoeducational handout and a sample Edge tool, and then another handout. And I think this will give you, I'm trying not to have people use the link, and I got to just get the link down because it's broken. So I'm trying my best to sort of figure that out. So I connected it to this thing. And if you add to this, you'll get this handout, and you'll get the Edge tool, and you'll get another tool that I'm going to talk about. So, okay, I'm going to reshare something else. This is a very old PowerPoint that I had on my website that I had when I did this training. So one of the things that I've done with this training is, and how much of this can you see? Can you see the screen? Psychoeducation and parent coaching.
I can see it.
Okay, good. All right. So when I developed this program, what I did is I was able to do a whole section on psychoeducation, and I became known in the community as the dietitian who did psychoeducation. And I think part of it is that this has been in the research papers by David Garner for years. And if you even Google his name, you could find papers and stuff about psychoeducation and eating disorders. The other link I just posted in the newsletter was that they're saying, oh, this works so much, this is so effective for mental health, for all these other issues. So with eating disorders, psychoeducation really ties the symptom to the malnutrition. And if you can help the client tie their symptom to the lack of food and nutrition for their body, that may help a little bit of motivation. Not always, because we know that eating disorders, specifically anorexia, restrictive type, is egocentric. They do not believe they have, and it's a cognitive place where they do not believe it's related to them, or they're doing it on purpose, and it's completely detached basically from what they are going through. So we have to describe the symptoms of starvation, and that's one of the things that we know from the Ansel Keys study. Many of you know about that study. I'm not going to go into it, but that is the framework of where these symptoms come from. And the Minnesota Starvation Study revealed from their tracking of men, interesting, no women, had a lot of different symptoms and behaviors. So a lot of these are on the edge tool. As we know, starvation impacts every organ system. And this brings me, and which we're going to just talk about two of them in our next, I don't know, I think we have like 10 minutes or so. We're going to talk about two of the symptoms, and the specific one that I like to do. And again, I know, Julie, you don't do the pulse, but I really feel like taking the pulse or getting a pulse is an effective tool, especially when you're initially starting with a client. So the reason why I do the pulse is that you can actually follow the calorie changes in the nutrition and how it impacts the weight. So for example, if I take a patient's pulse, and I always ask permission, I take it, I'm watching my watch, and I take it for 15 seconds, and then I multiply by 4 and I get beats per minute. Well, we do know that bradycardia is any heart rate below 60 beats per minute. So I create the urgency to the parents and the patient when the heart rate is below 60. Now, if it's below 50, it's very common when I was running my practice that I would tell them that I would recommend that they would go into their pediatric doctor like that day to get an EKG. And I would call the pediatrician and say, I need her to have an EKG today, because I felt liable with that information. So maybe it's a reason for dietitians to go, wait, that's too much information for me. I've had heart rates in the 40s. I think I remember 39 at one time. These are like high alerts, huge red flags that you need to get hospital attention, because when you sleep, your resting heart rate goes lower. So they're sitting after like maybe 20 minutes of the session or something, and you're taking the pulse when they lay down at night and try to sleep. When one of the patients helped me understand this, that when they wake up at night, it's actually their heart getting too low. So when you explore them waking up at night, you might want to ask what is happening when they wake up at night and what are they noticing? It could be the hypoglycemia, or it could be the low heart rate. So I think this is an interesting thing to explore. It's not just anxiety. They can't just fall asleep. It's just that their body is waking them up because their heart is dropping. So one of the things to do about this is help them understand that this is when I tie in the metabolic rate. And I talk about how our bodies have to run every organ system. And so we need fuel to run every organ system properly. So over the last 3 months, over the last 2 months, you haven't been able to get enough nutrition in your body. So the body has an adaptive response. It is so smart. It starts slowing everything down to preserve energy, because there's not enough energy around to run the systems. Normally, they start shutting down. The research shows that the metabolic rate can drop by 40% in someone who is starved. So your heart rate starts going, okay, instead of running at a normal place, I'm going to slow things down. Well, a slowed heart rate will reduce the blood flow to your extremities. Your feet are going to get cold. Your hands are going to get cold. You can do the capillary refill time if you really want to. You can see how fast the purple or the returns in your fingers. What happens is that your body, you're not going to have as much energy because your heart rate is slower. You're just not going to, you're going to feel maybe weaker. One of the things that can happen is that your blood pressure cannot adapt from laying to standing, and you can have dizziness. So I noticed you checked off dizziness, and this is actually part of the problem of a low heart rate from not getting enough fuel. Now, I want to give one aside here. I had a very young 11-year-old girl who came in, and they had been to like 5 doctors, all kinds of specialists. Nobody could tell them what to do. It's clearly malnutrition. I took her pulse. It was 125. I couldn't figure it out. And I was, because of her BMI and the chronicity of that, I just told the mom that she probably needed to pack her bag and take her to the ER, but because I couldn't figure out what was happening, that her heart rate was so high. I do know dehydration impacts heart rate to go higher. So it turned out that she had pericardial perfusion. I think it's called perfusion. So she had fluid around the heart that created this very, very high heart rate. So, I mean, I did not know what was happening, but I just knew something was really wrong. And because with the recall and the weight loss and her age, and I was like, how is she having this high heart rate? She was hospitalized for like 10 days. She's doing great. She just graduated college. I mean, these are all things that like amazing kind of things now that you look back and you go, and I was able to follow up with her mom recently, and she said, I don't know what would have happened, because we had gone to every person we knew to talk about this. We went to the GI, we went to the cardiologist, we went to the GI doctor, the endocrine doctor, we went to the primary doctor, a specialist doctor, and nobody could say anything. And it was malnutrition. And she was a dancer. So anyways, this is a motivation to do the heart rate. Now, what I wrote down on the interpretation, it says when malnourished, the heart rate will drop to preserve energy. Orthostatic changes causes dizziness. Without adequate body fat, you have less insulation, and a starved body attacks its own heart muscle. So even talking about a starved body will shrink your heart, it helps like the athletes think about, okay, you're trying to find out what in this client would motivate them to change. And the brain sometimes motivates the intellectual, kind of high achieving, studious people. The heart may, motivate the athletes. So, and I just talk about, hey, the answer to this is putting fuel in the furnace, 3 meals, 3 snacks, fuel in the furnace. And so that's the way I would talk about this one part with psychoeducation. Now I'm going to go down to the handout that's on this the website. And this was adapted from Winning the War Within. Is anybody familiar with that? I know she's updated it since. I don't really think, like, I'd like your feedback right now if you have any thoughts on what you feel about having this information here. I sometimes thought it was helpful. I said, do you know how much energy, if you were just sitting in your chair all day doing nothing, how much energy would you burn? Kids will go 0, I don't know, and I was like, well, your heart needs energy to run, your kidneys, your liver, your brain, your skeletal muscle. So when the body gets fewer calories than what's needed, the vital organs get less than what they need to function, and everything slows down, doing damage. So after I have the EDGE tool, I sometimes just go through this list with the teen, and I say, you have this, you have circulatory problems, you have digestive problems, okay, endocrine if it's applicable, dry skin, lanugo, personality. Now this is the one that it's sort of maybe under the general rule. Usually those close to you will notice an increase of moodiness, a quick changing attitude that may occur from not getting enough fuel or glucose to the brain. Moodiness, isolation, and depression may result. So again, this is a tool. I'm trying to probably refresh it, update it a little bit. I'm curious if what people think about putting numbers in there, because I typically don't talk any numbers to the teenager. Next week, my plan is to do psychoeducation part 2 and talk about the metabolism pendulum a little bit, and how the metabolism can actually swing from hypometabolic to hypermetabolic, and then what all that means with dietitians predicting symptoms. So to build that trust, when you start telling and predicting what's going to happen, it builds that trust to your clients to go, oh yeah, Julie said that would happen. Wow, she okay, I'm not nervous. This is happening for a reason. So we really can use psychoeducation to help explain symptoms and predict symptoms, and then empower them to have a little more motivation for change. So with that being said, we just have 5 more minutes. I was going to try to do 2 systems, but at this point, we're going to just have to stay with the heart. Does anybody have any questions with the heart rate and testing the heart rate? Do they do the heart rate? I'm going to give you something in the chat. It's a link to a blog that I wrote about taking a pulse. Anybody have any questions about this part? Okay, here's this. If I see clients remotely, would you have them take their heart rate if it can't be done in the office? Okay, so I actually work with parents of teens. So I have the parents take the heart rate and put it in a Google Doc along with their blind weight. And in the beginning, it's a little bit harder to rely on because if they're having dizziness, I absolutely have them do it, because the dizziness means they probably are having bradycardia. So, and that would be something that I would insist on. And if they are having trouble doing that, then I would just say, you know, we have to have you seeing your pediatrician every week, because I'm going to need I'm going to have orthostatics. So orthostatic is when the physician takes the pulse laying down and sitting up. And if you can get that done in a doctor's office, that's better, because really to have a parent do that, it's a little bit harder. But I talked to the teenager and I said, listen, if you wake up in the middle of the night and you're waking up, I want you to just try to take your pulse. And then I want you to tell your mother what you got, because we want to empower the patient to know that this is connected to this, right? This is not just something that's, oh, it always happens. Like I had a runner, she's like, oh, you know, I'm still having a little dizziness, but that's, you know, everybody has that when they go from sitting to standing, or when they get up really quick. And I said, well, actually, no, that's not normal. Just like, you know, athletes might think missing their period is normal. So again, I would just, I would encourage everybody to just try to do the full, like take the pulse when you can, because when you refeed, this is what I want to share. The first week, the pulse, let's say they followed your recommendation, they increased 300 to 500 calories, they're doing well, the parents are doing it, the pulse is going up, the weight is going down. And you cannot be unhappy with the weight going down. Otherwise, the parents feel discouraged. They're like, we did all this stuff, the weight went down. So sometimes I give no feedback on the weight. And I say, you're doing exactly everything right. The pulse is up. We're going to have to keep up. We're going to have to do a metabolic addition to the meal plan. We're going to do a metabolic addition to the meal plan. So to keep up with your metabolism. And then that it's all about the body. It's nothing about, you know, you did something wrong. You didn't do enough. Because I see the pulse go up, I see the weight stay the same or go down. And this may take 2 weeks before the weight starts coming back, as long as you keep up the meal plan up with the metabolic rate. So, hey, it's about the top of the hour. I just want to thank everybody for taking their time. If any of you have a case study that you would like to share, just reach out to me. You know, and then I would love to just talk. If you have any comments, concerns, input on the Edge tool, that would be very helpful. And then ideally, you know, what Julie's going to be doing with this like pediatrician kind of training, I think just a work group would be great if you're really in that position to come up with ideas, contribute. This is how things get done, you know, really. But I just want to thank everybody for today. Like I said, next week we'll do psychoeducation part 2. We're going to be covering the nervous system, the brain, and digestion. We'll try to do all of that. And then we're going to talk about the metabolism pendulum. So.
Thank you so much. This has been phenomenal.
Thank you for attending. And then Heather, do you want to say who you are real quick? Because we want to finish. I'm happy to go 3 minutes over, but if you wanted to introduce yourself, that's fine.
Sure. Can you hear me still?
Yeah.
Oh, good. Now you can hear me. I think my microphone was switching over for some reason, but my name is Heather Bainbridge. I'm a dietitian. I see clients outside of Philadelphia, Pennsylvania. I have eating disorders, disordered eating, and also a general practice. And so the more, and I have Melanie use the Edge tool. I just started to use it. I just learned of it. So I have done it with one client. And so this has been helpful in terms of, and I think I downloaded it actually a while ago. And so there's some extra information that wasn't on my copy. So I look forward to reading through it.
Okay.
And hearing today how you utilize it has been tremendously helpful. So thank you for doing this.
Sure. I'm happy to do it. And next, like I said, next week, we'll go over the other psychoeducational pieces, which again, you can do very briefly, or you can just focus on one that you might think would motivate the client a little bit more, and then weave in psychoeducation pretty much every session to the client. I do the nutrition education to the teenagers, parents, and the psychoeducation to them both. So not a lot of nutrition specifics other than you need more fuel, you need to eat more frequently, we need to get fuel in the furnace. And then I would split more the nutrition education to the parents in the early stages. Of course, eventually the teen can get more of it, but not in the beginning because they just can't grab it. So, all right, well, thanks everybody. I'm going to sign off. And if you have, again, reach out if you have any questions, comments, or thoughts, and come back with a case study. We'll see how many more case studies I can get. I have some other people that I'm tapping to share their use of the Edge tool.
Thank you.
All right. Thank you.
Thank you.
All right. Bye, everybody. And